Let's begin with asthma signs and symptoms. When discussing signs and symptoms with the patient and caregiver, our goal is for them to learn to recognize signs and symptoms of asthma and provide early intervention with a rescue medication. Some signs and symptoms include chest tightness, shortness of breath, inability to do their normal activities, wheezing, coughing, or coughing at night. When a caregiver recognizes a sign or symptom, they need to treat their child quickly so as to prevent the patient's condition from worsening. If a patient recognizes a sign or symptom, they need to tell an adult as soon as possible. This includes parents, coaches, teachers, etc. Next, let's discuss asthma medications. Specifically, let's address the difference between control and rescue medications. Control and rescue medications are just like they sound, to control or keep asthma symptoms at bay, or to rescue the patient when they need help. Not every patient is prescribed a control medication, but when they are, it is important that they understand that it is a medication that needs to be taken every single day to prevent asthma attacks. If the patient or caregiver has difficulty remembering to give the control medication, you may suggest that they keep it by their toothbrush or on their nightstand so that they remember to take it every morning or every night. On the other hand, every patient will go home with a rescue medication, either an inhaler, nebulizer treatment, or both. The Asthma Action Plan indicates when and how the child should use these medications. It is important that the child has access to their rescue medications at all times, including at school, the store, a sports practice, or even a friend's house. Next, we'll discuss triggers and control. A trigger is exposure to something that triggers asthma symptoms. There are many triggers out there, and each patient may have a different trigger or triggers. Triggers include, but are not limited to, colds, flu, or infections, weather changes, fragrances, seasonal allergies, dust, mold, exercise, grass, emotional stress, smoke from cigarettes or fires, air pollution, and animal dander. If a patient or caregiver does not know the patient's trigger, they should keep an asthma journal or diary to track potential triggers. Once the triggers are identified, it is important that they understand how to limit patient exposure to or how to control a trigger. Some examples include not allowing smoking in the house or in the car, not allowing pets in the room or on the bed of a patient, taking seasonal allergy medications, and teaching proper hand hygiene. Our next topic is the Asthma Action Plan. An Asthma Action Plan is written by the physician and reviewed with the family prior to discharge. Information on the plan includes follow-up physician and information, green, yellow, and red zones, much like a stoplight, indicating how severe the patient condition is and how to treat it, and a list of the patient triggers. The green zone at the top indicates what to do when the patient is feeling well. This means that the patient is breathing normally, can work, play, or exercise like normal, is not coughing or wheezing, and is able to sleep through the night. If a patient is on a control medication, it will be listed here as a medication that needs to be taken every day, no matter what, usually twice a day. The yellow zone indicates that the patient is doing worse. They may have coughing at night, have mild wheezing or shortness of breath, and decreased ability to do their normal activities. When they fall in this zone, always follow the green zone instructions or the control instructions, and then add the medications for the yellow zone. Often this is a rescue medication, either Xopenex or albuterol, every 4 hours as needed. The patient may also need to use their rescue medications in this zone if exposed to a trigger, but before the patient feels worse. If the yellow zone is not effective in treating the patient, they need to move to the red zone. Again, they will always continue the medications from the green zone or the control zone, but they will initiate the emergency instructions in the red zone. This means the patient cannot do their normal activities. Their lips may be turning blue or gray. It's getting harder and harder to breathe. Their nostrils may be flaring when they breathe, and the patient has difficulty walking and talking. This zone is unique to each individual, but often involves taking rescue breathing treatments back to back to back while seeking care from their healthcare provider, or if necessary, going to the emergency room or calling 911. They should know that once in this zone, asthma can be life-threatening and it is important that they receive care as soon as possible. It is also important that caregivers receive their asthma action plan at discharge. If the patient attends school or daycare, please ensure that they have an extra copy at each of those facilities in case of emergency. Finally, we will discuss asthma equipment. Later in this video, you will learn more about using asthma equipment from a respiratory therapist. At this time, I'd like to discuss the use of the peak flow meter and the spacer or spacer and mask. A peak flow meter is a tool that patients can use to measure how well air moves out of their lungs. At Medical City, we attempt peak flow readings around 7 years of age, although not every patient is able to use this tool well. Even when they aren't able to get accurate readings at this age, we provide them with a peak flow meter as a tool that they can use as they grow older and are managing their asthma on their own. Once able to use accurately, peak flow readings should also correspond with the signs and symptoms of the green, yellow, and red zones of the asthma action plan, giving the patient another way of knowing how well controlled their asthma is. As nurses, we should ask the respiratory therapist to begin peak flow teaching once the patient is changed to breathing treatments every 3 to 4 hours. A spacer, or a spacer and mask if 5 years old and below, should be used for every inhaler breathing treatment. The spacer allows more of the medication to enter the patient's airway and lungs rather than coating their mouth or throat. If being sent home on an inhaler, the respiratory therapist needs to review spacer teaching with the family prior to discharge and provide them with a spacer to go home with. If the patient has a backup inhaler at school, they should also have a spacer available for use there. As nurses, please notify the respiratory therapist early if a child needs education with asthma equipment. It is also our duty to make sure that caregivers take home the patient's supplies, including inhalers, spacers, masks, and nebulizer tubing. Let's take a few moments to discuss barriers to education. For those patients who are admitted on continuous breathing treatments or in the middle of the night, these are understandable barriers to education. At times like these, it is acceptable to mention the importance of receiving asthma education during their stay, but to defer the teaching to a more appropriate time. You may even provide the materials at the bedside to review at the later time. Other barriers may include patient age, lack of caregiver presence or interest, or health literacy levels, to name a few. Child Life will review a number of resources that we have available, improving the educational experience. At challenging times like these, we should emphasize the importance of education and self-management, use teachable moments such as during medication administration or discussion of the plan of care, and remember to keep it simple. As nurses, we're not here to overwhelm, we're here to help. Finally, please be sure to document your education during the patient's stay and at discharge in the electronic health record.